have chronic fungal infection of the lungs, okay, right? So for you to be able to manage anemia of chronic disease, you must manage the underlying disorder. For example, if a patient has rheumatoid arthritis or SLE, then you need to first of all manage the SLE or rheumatoid arthritis for you to be able to manage anemia of the chronic disease that is brought by either rheumatoid arthritis or SLE. If a patient has chronic kidney disease, you don't manage the chronic kidney disease. You don't manage only the anemia. You manage the chronic kidney disease, then automatically you're going to ensure that you manage the anemia. Sorry. Let's continue. So what we are saying here is that the degree at which, so what happens is that for you to be able to manage, okay, for you to be able to sufficiently manage the anemia of chronic disease, what happens is that it will depend on several factors, okay, right? Or several other factors that of course will or are contributing to the anemia of that chronic disease, right? Now, one of the things, of course, is, for example, if a patient is having, let's say, blood loss, deficiency of iron and folate because of either there's poor absorption due to inflammatory process that is occurring probably in the stomach mucosa. For example, if a patient is suffering from chronic atrophic gastritis, right? Then what happens is that, of course, you may end up giving a patient the supplements, okay? All right. Of course, blood loss, right, should be treated. And that blood loss, of course, needs to be taken in terms of where that blood loss is coming from. We need to ensure that that blood loss, of course, does not continue, right? If there's a deficiency of iron and folate, of course, that one needs to be sorted out in terms of, for example, if the patient has inflammatory process that is occurring within the mucosa, then you have to bypass the mucosa and probably now give the patient in other forms, all right? Let's say, for example, parenteral. Then this may end up, okay, so you may end up not transfusing the patient, right? Or erythropoiesis stimulating agents such as EPO, right? If a patient has chronic kidney disease, of course, now because the kidney produces erythropoietin, then what you may need to do is that you may need to give erythropoietin, right? Apart from, for example, if a patient comes with severe anemia, you may need, first of all, to transfuse that patient. And of course, now continue giving erythropoietin in terms of stimulating bone marrow to produce the red blood cells so that now it can be able to keep on producing its own blood cells. For you to be able to make the diagnosis of anemia sufficient, then what happens is that you need to ensure that you do all your sufficient studies, okay? For example, you need to ensure that if a patient has occult bleeding, if the patient has occult bleeding, so these are patients that probably may employ something like a colonoscopy or need to do an endoscopy for you to be able to find out exactly where the bleeding is coming out. You may need to do your iron and vitamin B12 serum, okay? studies or investigation, right? You may also need to find out if the patient has hemolytic and drug reaction that is causing actually this anemia. Therefore, what happens is that once you are able to identify the cause, then of course the underlying disease is treated. So we are looking at therapeutic options for anemia of chronic disease. The treatment option number one here is treatment of underlying disease. If it is anemia of chronic disease, yes, you must treat. Anemia of chronic disease with true iron deficiency, yes, must also treat. Okay. Reason is because if you're just going to treat the disease without treating, we have anemia of chronic disease with true anemia. So what happens is that you must treat the underlying disease. The reason is because if you don't treat the underlying disease, then the iron deficiency will continue, okay, to ensue. Transfusion is the other element of treatment of anemia of chronic disease, right? Yes, you must do. If it is anemia that is due to iron deficiency, you must, okay? Reason is because the transfusion, of course, carries iron. Iron supplementation, okay? In anemia of chronic disease, no. The reason is because you may have anemia, okay? You may have anemia. Now I'm explaining this point why you are not supposed to give iron supplementation. You may have anemia, but that anemia may not be anemia due to iron deficiency, right? It might be anemia of chronic disease, but not due to iron deficiency, okay? But if it is anemia due to iron deficiency, and of course you need to do your full hemogram and you also need to do your iron studies, okay? You must do your full hemogram and also you need to do your iron studies. Then your iron supplementation will be supported. When it comes to the treatment option of using erythropoietic agent, if it is anemia of chronic disease, of course you can use, right? You can use erythropoietic deficiency, agents such as EPO, right? Here, you can choose an example such as chronic kidney disease, right? What happens in anemia of chronic disease with true iron deficiency? Yes, again, patients who do not have a response to iron therapy, okay? You can be able to of course give erythropoietic agents. Let's look at erythropoietin. What is erythropoietin? Lack of erythropoietin, okay, usually leads to anemia. Usually what happens is that erythropoietin, right, is usually erythropoietin is a hormone that usually stimulates the bone marrow to produce the red blood cells. So what happens is that in some forms of other forms of anemia, such as primary bone marrow disorder or anemia or secondary to cancer chemotherapy, right? What happens is that this erythropoietin is very, very important. Okay, of course, it has its own drawbacks and toxicity as you can do there. I want you to look at this point here. Supplementation with iron may be required to assure an adequate response. Now, what are we saying here? Is that erythropoietin is only supposed to be used to stimulate production of red blood cells. Production of red blood cells, right, can be mature or immature red blood cells that can be produced. I repeat again, erythropoietin, right, when it is given, it leads to adequate response of the bone marrow to produce the red blood cells. And the red blood cells that are produced can either be mature or immature red blood cells. And therefore, erythropoietin does not care if you're going to produce those cells. What it does, yes, it stimulates them to be produced. And therefore, when you're giving erythropoietin, the other thing that you must ensure that this patient gets is that this patient must also get iron supplements. And when you are managing iron deficiency anemia, we say that you can be able actually to give this patient parenteral iron. And therefore, what we are saying here is that as you give the patient, okay, as you give the patient erythropoietin, you must also give the patient iron, okay, for you to be able to have enough iron stores. Because what happens is that when you start producing the red blood cells, these red blood cells, for them to be able to have adequate amount of hemoglobin level, they will need adequate amount of iron. Okay? Of course, you're saying that this one is usually administered intravenously, especially renal dialysis patient. Okay, but it can also be given as a subcutaneous route. So erythropoietin is used to, especially when you have low HP, okay, and when you have serious cardiovascular events, okay, shortened lifetime, especially when you have tumors or decreased survival rates of the red blood cells, okay. The dosage of erythropoietin, all right, usually about 50 to 100 micrograms per kg, usually 3 times a week, subcutaneously or IV, when the HP is less than 10 grams per deciliter. So you need to reduce the frequency once the HP is more than 10 grams, okay? We say that ensure to give iron supplements, and parenteral iron supplements are more better than giving the oral, because oral, of course, it will take time for them to be able to be incorporated into the iron stores. We say that hemoglobin levels are between 10 to 12 grams per deciliter are usually reached within 4 to 6 weeks of iron level, if iron levels are adequate. So iron levels must always be supplemented in this patient. Thank you. Any question up to there? All right. So we shall look at aplastic anemia in the next few minutes. Just trying to load my my slides. Sorry. Just give me a few minutes. We can load that slide. Good. So let's kindly look at aplastic anemia in the next like 15 minutes. We should be through with the aplastic anemia. Not so many slides, just a little bit of that. Now, one thing I have to tell you is that anemia is a very long topic. Anemia is a very, very long topic. We can talk about anemia from morning to evening. We are going to talk anemia in obs and gyn, and I'm sure you must be doing something about anemia in obs and gyn, right? So we should be able, we may not be able to finish exactly everything that we need to finish in anemia here, but at least whatever I've given you should be enough for you to be able to navigate yourself, okay? Because you will always be meeting patients who have anemia, whether in the outpatient or whether you are managing patients in the inpatient department, okay? Therefore, as you can see, anemia is actually a condition that we cannot be able to finish with just one day. We have to talk about anemia like forever. Let's continue. So what we call a classic anemia, all right, is when you have a reduction of all the cells lines, okay? Then there's replacement of bone marrow with fat, all right? So this is known as pancytopenia, right? And the causes of pancytopenia or plastic anemia can be inherited, right? Inherited condition, Fanconi anemia, all right? That is the one that affects the bone marrow. It can be acquired through chemical or through, idiopathic, anything that, of course, you may not be able to know what is the cause. Drugs like normophenical, this one causes gray baby syndrome, okay, right? This chloramphenicol is harmful to the bone marrow. Chemicals such as benzene, infection or infectious processes, or infections such as viruses, okay? Viruses here we have hepatitis, Epstein virus, and of course we have primary malignancies, myeloproliferative or lymphoproliferative disorders. I hope we are going to cover the myeloproliferative and lymphoproliferative disorders. Okay, I hope we are going to have time to cover that. Right. So we see that aplastic anemia is caused by bone marrow failure, that is decreased production of all cell lines. So we have reduction in production of red blood cells, reduction in production of white blood cells, reduction in production of platelets. Okay. So you get a patient, okay? You get a patient, do a full hemogram, you have a history of that patient, you do a full hemogram, but before you do that, you must evaluate the history of that patient, okay? Right? So you need to do your full hemogram and look at the red cell indices. You need to do your peripheral blood film, you need to do your bone marrow aspirate, you need to do your iron studies, and you need to do your ESR. All these are very, very important. Okay? Together? That is a short presentation of what we call aplastic anemia, right? Plastic anemia. So I think I'm going to send you some history, some patients, for you to be able to do some revision on what we have discussed in terms of anemia. I want us to probably stop there in terms of anemia. I'm just going to send you some few notes, especially on hemolytic anemia, which I'm very sure you're going to cover, especially in your obs and gyn. Therefore, that should be just some additional notes for you to be able to carry. But I'm not going to, I don't want to cover hemolytic anemia. because in terms of the representation here, hemolytic anemia will be more found, especially when you're dealing with those kids who usually come with jaundice. All right. Therefore, I prefer more to deal with aplastic anemia, iron deficiency anemia, and anemia of chronic disorders more than hemolytic anemia here. So I think I want to stop there for today. And, and we shall continue next time. We jump on to another topic. We leave anemia alone as you continue.